So the question is, which is false? IgM lambda MGUS often progresses to multiple myeloma. IgG MGUS can be associated with DLBCL, diffuse large B-cell lymphoma, and light chain amyloidosis may occur in all paraproteinemia. Give everyone a chance here. Feel free to discuss with your neighbors. And so the answer here is A, IgM lambda MGUS often progresses to multiple myeloma. And so, when you look at these cells that are producing these monoclonal antibodies, if once these B cells become more defined in their role and eventually become plasma cells, they tend to secrete more sophisticated antibodies. So they tend to be IgG, IgA, IgD, IgE, as opposed to the IgM, which tends to be produced by earlier B cells, or what we call lymphoplasmacytic B cells. And so when they are producing the IgM lambda paraprotein, you're not so much thinking mutation in the plasma cells, but the B cells. And so these patients tend to turn into things like lymphomas as opposed to multiple myeloma. And therefore, when you're encountering IgM lambda paraprotein, it's important that you are examining them for lymphadenopathy, for hepatosplenomegaly, to look for signs of AL amyloidosis, but not so much the skeletal survey to look for bone lytic lesion, because you're not so much anticipating that these patients would turn into multiple myeloma. So our next topic is by Dr. Gillian Mount, and she will be discussing overview of common hematologic malignancies with focus on treatments and prognosis. And so Dr. Gillian Mount is a recent addition to the Division of Hematology. We're very excited to have her. She's an assistant professor of medicine at Western University, where she focuses on both clinical and academic roles. In addition to providing comprehensive inpatient care, her expertise lies in managing hematological malignancies. Dr. Mount also has a particular interest in early integration of palliative care, aiming to enhance patient comfort and quality of life throughout their treatment journey. She's got nothing to disclose. And so these are the learning objectives. Discuss the prognosis of various types of common hematological malignancies. Review treatment, including curative versus palliative intent options. And so the case continues. And so what's happened to Richard? So 3 years later, now Richard is 65. He's now presenting with progressive lymphadenopathy, unintentional weight loss, night sweats, and fatigue. The physical examination is enlarged, showing cervical and inguinal lymph nodes that are palpable. And he also has mild hepatosplenomegaly. The ultrasound-guided core biopsy for lymphoma protocol revealed non-GCB subtype, diffuse large B-cell lymphoma. And so what should we do? What key details will you disclose to your patient about prognosis and possible treatment options? And so back to the app, your question is listed there and your answer options. Option A, stage 4 DLBCL is curable with treatment. Radiation therapy will be required. If Richard is 85, treatment is no longer curative. And relapsed DLBCL is no longer curable. And so the answer here is stage 4 DLBCL is curable with treatment. And so aggressive lymphomas in general are treated for cure. And so even if they present with advanced stage disease, at stage 4 out of 4, treatment can still be curable for most patients. Even if they are aged above 85, multi-agent chemotherapy can still be successful in curing a proportion of patients. Radiation therapy is now not necessarily required in all patients. Sometimes we used to use it quite often in patients with limited stage disease, but even so, now we have data indicating that perhaps chemotherapy alone may be sufficient in curing these patients. And patients who relapse with their DLBCL, their disease can still be curable with subsequent therapies, including potential stem cell transplant. And so I'll invite Dr. Mount to come up here to the podium to present her talk. Thank you, Dr. Mount.
Okay, hopefully I can use this. Okay, so nothing to disclose. Dr. Pua has kindly gone over the objectives. And really what I want to focus this on is the information I'm going to share should not and will not replace the conversations that we have with patients either on the ward or in the clinic. But it's really to hopefully provide you guys with a framework of at least baseline information about some of the more common blood cancers that you're going to encounter so that you guys feel more comfortable having these conversations at the time of diagnosis with patients. There are dozens and dozens and dozens of different types of blood cancers that we deal with. Obviously, for the sake of this presentation, there's far too many for me to go into. So I've decided to highlight the more common ones that you guys are going to see. And for the sake of this clinical case, we are going to talk about diffuse large B-cell lymphoma. We're going to talk about follicular lymphoma, CLL, and then we're going to finish up with multiple myeloma. It's going to be a kind of a whirlwind quick overview, but hopefully you get some information to take back with you to your own clinical practice. So diffuse large B-cell lymphoma is the most common of the aggressive types of non-Hodgkin lymphoma. And what I tell patients is that once they have a tissue diagnosis of a non-Hodgkin lymphoma, it's really not useful for them to go down that Dr. Google rabbit hole of looking up prognosis on the internet. There are dozens of different types of non-Hodgkin lymphoma, and they can span quite a breadth of different types of prognosis and treatment. On one end, you will have, oh, didn't work. There we go. On one end, you can have the more indolent, quiescent types of lymphoma, such as your follicular and your CLL, which are very treatable, but not necessarily curable. And then on the far end, you're going to have your aggressive types of lymphoma, your DLBCLs, your Burkitt's lymphoma. And then you have a number of non-Hodgkin lymphomas that fall in between that. The treatment and the prognosis of these lymphomas differs greatly depending on which end of the spectrum that you're on, which is why it's not useful for them to just Google non-Hodgkin lymphoma. So speaking of diffuse large B-cell lymphoma, these are often patients that don't present to your clinic with just kind of, oh, I've had this lymph node for a couple of years, or I kind of feel generally unwell for the last, 6 to 12 months. These are often patients that present very acutely. These are patients who present to you saying, I have this rapidly enlarging node in my neck, or they have constitutional symptoms, pretty profound weight loss, 20, 30 pounds, fevers, night sweats, or they can actually present in a life-threatening manner to the emergency room with end organ dysfunction or evidence of other things that we'll talk about in a later presentation. Once we have a tissue diagnosis of diffuse large B-cell lymphoma, then we look at the staging process. Many of these patients already come to us with CTs, which is great. We will get a PET CT at baseline to look for microscopic disease, and then that allows us to also check halfway through therapy to ensure that they're responding, and then at the end of treatment. Bone marrows are not necessarily routinely done anymore. PETs are very good. There are obviously your own specific cases where we may require a bone marrow at the time of diagnosis. And similarly, lumbar punctures are not routinely done unless we think the patient has a higher risk for CNS disease. This is a schematic looking at how we actually stage lymphoma, looking at where the lymph nodes are located, above, below the diaphragm, as well as any extranodal disease. And I make a point that staging for lymphoma is very different than it is for our solid tumor counterparts. A stage 4 lymphoma is prognostically not that far off from, say, a stage 2. And as I'll touch upon later, the treatment is still very different. The treatment is the same for a stage 4 diffuse large B-cell lymphoma as it would be for an earlier stage, unlike what we'd expect in something like a colon cancer that was stage 4. When we have a talk with our patients in clinic or on the ward about what their prognosis is going to be, we don't just pull numbers out of the air. we actually use something called the RIPI, which takes into consideration a patient's age, their fitness level, baseline blood work, as well as staging information. And this, we can help to risk stratify patients into very good, good, or poor. And this information we can provide to patients to say, overall, this is what we expect that your overall survival will be. I want to highlight the fact that even those patients who are poor risk still have an overall survival at 4 years of greater than 50%. So those are your elderly, frail patients. And when we talk about first-line treatment for DLBCL, we are talking about R-CHOP, probably the most common chemotherapy that we provide at the cancer center and on the ward. This is given for curative intent. So as Dr. Pua highlighted in this clinical case, even for stage 4 diffuse large B-cell lymphoma, we give chemo to cure them. And this is a combination chemoimmunotherapy composed of a monoclonal antibody such as rituximab. And it's put together with more of traditional types of chemotherapy. So cyclophosphamide, doxorubicin, vincristine, and then patients go on a 5-day course of high-dose prednisone, usually 100 milligrams. And this is a calendar that we provide those patients. So they come to the cancer center on day 1, they get their IV chemo, and then they go home to complete their course of prednisone. This is administered every 21 days for usually 6 cycles. And how do these patients do? So there was a recent trial out of the New England Journal. This was looking at another type of monoclonal antibody combined with CHOP. It's called polatuzumab. And the idea here is not to really highlight the difference between the two regimens, but really to draw your attention to the patients who received R-CHOP, so the control arm group. You're looking at intermediate risk patients having a PFS of 70% at 2 years and an overall survival of 88% at 2 years. So really the take here is that DLBCL, very aggressive type of lymphoma, but even those that are higher risk, we still treat for curative intent, and these patients can do exceptionally well. So moving on into follicular lymphoma. So this is the most common of the indolent-like types of lymphoma, and probably the most common indolent lymphoma that you'll see in your general practice. In contrast to diffuse large B-cell lymphoma, these patients often present with an insidious type of presentation. These are patients who get diagnosed kind of, oh, I've had this lymph node for, I don't know, years now. Or as we often see, patients have biopsies for other reasons and it gets incidentally picked up. Most of these patients are advanced stage once they get diagnosed, and the later stages of follicular lymphoma are considered to be incurable. We do something called the FLIPI, which is like the RIPI. It takes into consideration patient characteristics like their age, and as well as their blood work and staging to prognosticate them. And obviously the numbers are not quite as good as you would expect for like DLBCL, which is a curable type of lymphoma, but still pretty good. When we talk about first-line treatment for follicular, oftentimes these patients don't need treatment right away. So again, these are largely patients asymptomatic with low tumor burden who get picked up, and we can watch and wait those patients for some time in the cancer clinic. When we do see that patients either become more symptomatic, so they develop constitutional symptoms, or we start to see that lymph nodes are growing rapidly and causing obstruction, then we need to look at treatment. And that treatment tends to be something like bendamustine and rituximab. This is a combination chemoimmunotherapy. This is a palliative intent chemotherapy, meaning that we are not looking to cure their follicular lymphoma with this. What we're trying to do is control the disease and hopefully control it for many years. This is, oh, this is a little bit small. This is administered every 28 days on consecutive days in the cancer center, and it's given every 6 cycles. This kind of a little calendar that we'll provide for it. And I guess the question of, well, what if we just gave them more aggressive type of chemotherapy? Will that make these patients live longer or have longer progression-free survivals? And the answer was answered in Rummel et al. Back in 2013, which used indolent lymphomas who were randomized to receive BR versus R-CHOP, and found that actually patients on the more gentle type of chemo, the BR, did far better with a median progression-free survival of approximately 6 years. So moving along to CLL, most common lymphoid malignancy in North America, certainly, and probably one of the more common ones if you're a practitioner. In the community, you probably see a lot of CLL. This is a disease of the elderly. So as our patient population ages, we're going to see more and more cases of CLL. And for the most part, these are probably patients that you've diagnosed. These are patients who've been having annual blood work and you slowly notice that lymphocytosis creeping up and you refer them to the cancer center. Or someone, again, who's had a lymph node kind of for a number of years and finally get a biopsy. CLL is diagnosed on flow cytometry. It's a peripheral blood test. It's not a bone marrow. And the decision to start treatment is really based off of whether or not the patient is experiencing any symptoms. What is the CLL doing? How is it behaving? Is it more aggressive? As well as looking at for autoimmune phenomenon or if there's any evidence of end organ damage or dysfunction such as thrombocytopenia and anemia. Most of these patients don't get treated right away. So you send those patients to the cancer center, we see them, we diagnose them with CLL, and we often send them back to you guys. And the reason is because there's no benefit to treating these patients early if they are asymptomatic. On average, these patients don't require treatment for up to 7 years. And we have good evidence for this even recently back in 2022 with the CLL-12 trial, which compared newly diagnosed patients randomized to either ibrutinib, which I'll talk about on another slide, or a watch and wait approach, which is the control arm. Again, I'm not trying to draw your attention to that ibrutinib obviously had a longer time to next CLL treatment, but to really show the focus on that watch and wait control group that 50% of these patients still did not require treatment at 5 years. When patients do need treatment, what do we look at? Well, traditionally, we always looked at chemoimmunotherapy. Many of you may remember a lot or seeing a lot of FCR. So fludarabine, cyclophosphamide, and rituximab. If you were a fit patient with CLL, if you were unfit, we used to use a lot of chlorambucil and obinutuzumab or BR once again. Now we have more targeted therapy. We're using a lot more ibrutinib and acalabrutinib, which are BTK inhibitors, so pills that patients take, or combination regimens with a BCL2 inhibitor such as venetoclax with another type of anti-CD20 monoclonal antibody such as obinutuzumab. And how are these patients faring? They're doing very well. So although CLL is not curable, it is readily treatable. And we're looking at PFSs for these patients of anywhere from 90%, 87%, 88% if you were fit or unfit, on a oftentimes all oral regimen that are very well tolerated. And lastly, we're going to touch upon multiple myeloma. About 10% of hematological malignancies right now are new diagnoses of multiple myeloma. And again, sometimes these are patients that you guys diagnose and send to us. So similar to Dr. Luzada's talk, these are patients with MGUS who gradually over time, we see that progression into multiple myeloma. Or these are patients who present in crisis, present to the inpatient ward or present to the emergency room with a pain crisis from lytic lesions or hypercalcemia or renal failure necessitating dialysis. Myeloma has made great gains in the last 20 years. So back in the 2000s, overall life expectancy was about 3 years, and now we're pushing closer to 10. Despite all of that, though, we still have to point out that this is an incurable type of blood cancer. When we see a new patient with multiple myeloma, the first thing we kind of have to think about is whether or not this patient is transplant eligible or ineligible. And if they're deemed eligible, that's usually based off of their age, their fitness, and organ damage that they have. And then we proceed with an induction type of chemotherapy. This is usually a combination, lenalidomide, which is an immunomodulatory pill, combined with bortezomib, a proteasome inhibitor injection with dexamethasone, and they'll go through a couple of these cycles and go on to an autologous stem cell transplant. And then we'll have some maintenance therapy with that. This is palliative chemotherapy. This is a difficult concept for patients and other hematologists alike because we're doing a transplant, but we're actually not trying to cure their myeloma. What we're trying to do really is to get as deep a remission as possible to give these patients as long of a remission time as possible. And when we do that, now this is a Kaplan-Meier curve that separates out by high risk versus low risk, but you're looking at a median progression-free survival of at least 5 years and overall survival of around 10. What if you're transplant ineligible? We based treatment then off of the Maya trial from 2019, and we used something called daratumumab, which is a monoclonal antibody anti-CD38, combined with lenalidomide and dexamethasone. And these patients did very well. So we see that in at least the clinical trial back in 2019, that their median progression-free survival was not yet reached. We've had some time for this data to mature, and we now know that median progression-free survival is around 5 years, median overall survival not yet reached for these patients, transplant ineligible patients, your older patients, your frailer patients. So the take home really from this, which I hope you take home, is that DLBCL is a very common type of aggressive non-Hodgkin lymphoma, but it is curable. And when we treat even stage 4 disease, even in old people, we treat to try and cure them. Follicular lymphoma is indolent, it's slow growing, it's incurable, but a lot of these patients do not require treatment up front. And once they do have treatment, we have really good, well-tolerated chemotherapy regimens, which will allow patients to remain treatment-free for some time. CLL is not like an acute leukemia. These are not medical emergencies for the most part. And that patients at the time of diagnosis will often be referred back to their family practitioners. They can continue to be followed, and they may not need treatment for many years. And when they do need treatment, we have really good, often oral regimens that will keep patients with their controlled disease for many years. And lastly, multiple myeloma is incurable. However, we still do transplants on these patients, and we still have really good outcomes even in those who aren't transplanted to push their prognosis for 10 years or more. Any questions?
Oh, wait. Oh. Oh,
Hi.
sorry. So is it fair to say for my CLL patients, unless they're having B symptoms, I don't need to send them back to you? Okay.
Yeah. I mean, we will see a lot of these patients in the clinic. We will send with our consultation note, we've diagnosed with CLL. They don't require treatment at this point, but we'll give guidelines as to when you need to repeat the CBC, and you need to watch as that white count is rising. I talk about that constitutional symptoms is one way that we would need to look at doing treatment, but certainly if we're starting to see progressive anemia and thrombocytopenia in these patients, or we're seeing that over the course of 6-12 months that their white count, their lymphocytes are doubling or increasingly getting high, then that would be another reason to refer back to the cancer center because they may need treatment at that point.
Any other questions? And so earlier you mentioned that follicular lymphoma, both are palliative intent treatment. Could you briefly talk about the patients that have newly diagnosed follicular lymphoma and on CT only identifies one area that is involved?
So I didn't touch upon it. So there are some limited stage follicular lymphomas, which we think can actually be cured. It's not a common presentation for follicular lymphoma. Oftentimes we see it as more widespread disease. Blood cancers, unlike other types of cancers, hop onto those lymphatics. They love to spread all throughout the body. That's just normal behavior. But if we do see it in just one localized area, then it could be considered curable with radiation therapy.
And so when diagnosing these patients, let's say a biopsy now shows a follicular lymphoma, what would you suggest as your immediate next steps?
Yeah. So if I'm the family doc or nurse practitioner who has that patient with that biopsy, sending that patient for a baseline blood work, CBC, creatinine, liver, LDH, and then looking at CTs. I kind of mentioned that we often get these patients referred to us with PAN scans, which is hugely beneficial because that allows us to look to see if there are any other areas of involvement that we need to know. We'll always get a PET CT, but it's always useful at the time of consultation to have at least baseline imaging of where the disease may be located.
Okay, thank you everyone. Thank you, Dr. Mount.